Welcome to the Truth and Fertility podcast. My name is Haley and I am your host. I work at an OBGYN clinic where I teach women and couples how to chart their cycles so they can either achieve or avoid pregnancy and also to manage their fertility. I have a huge passion to teach women and couples about the beauty of their fertility and how the pill is never the answer to women's health. There's a lot of good and not so good information out there about fertility. And so my goal with this podcast is to help you sort out the truth from the weeds. I want to teach you how to chart your cycle and to reach your family planning goals while also maybe even possibly locating hormonal imbalances and to receive proper treatment. I want to help you get in the best hands that you can with the best doctors that you can to reach optimal reproductive health. So if you're ready to get on this journey with me to learn more about your reproductive system, how it was created and how it should be working, and the best medicine in order to make it work if it's not, then you are in the right place. Welcome to the Truth and Fertility podcast. Today I have on an incredible person here, an incredible doctor actually, who we're talking to today. Her name is Dr. Minjeur. And you are learning about her just along with me. I don't know a whole lot about her, but I am incredibly excited to get to know her because what I do know about her is that she is a NAPRO doctor, NAPRO technology doctor. So I'm sure we'll get into all of that and what that means, but I'm really excited and blessed to be able to sit down with her today and just pick her brain about women's health and women's medicine and really just getting down to the root causes of things, true women's health and medicine, and really healing women rather than just placing a bandaid on them, right? So without further ado, Dr. Minjeur, if you want to introduce yourself and we'll just get started.
Yeah, thanks so much, Haley. I'm so excited to be chatting with you today and to talk to your listeners. So I'm Dr. Monica Minjeur. I'm a family medicine physician by training. And during my residency training, I actually got additional training as a NAPRO medical consultant. And actually, for the first 10 years of my career, I practiced full spectrum family medicine, including women's health and utilizing NAPRO practices. And about 2.5 years ago, I decided to actually leave my family medicine practice. I was employed by a hospital system and actually created my own clinic. So now I founded and I'm the CEO of Radiant Clinic. And we do have a brick and mortar location in Cedar Rapids, Iowa, right in the middle of the country, but we also provide telehealth services to women and couples all across the country. We actually have a couple of international clients as well, which is really exciting. So when I went to open that clinic, I actually got additional training in some other restorative reproductive medicine techniques as well. So some of your listeners may be familiar with FEM and neo-fertility, so I have some additional training in medical consulting there. And so really have been able to build this clinic where our whole focus is on helping women to restore natural menstrual cycles, to improve their health, to promote fertility. And we are just having a great time taking care of clients and helping to not only educate, but bring hope and bring light to these situations that are otherwise really scary and can be really dark for many women and couples. So we're having a great time providing the resource in our area as well as nationwide right now.
That's amazing. Well, so you said you were primarily in family practice. So are you also an OBGYN or are you still family practice, but you just specialize in women's health? Go into your specialty a little bit.
Yeah. So as far as a specialty goes, once you are trained in a specialty and you're certified in a specialty, that's what your specialty is. So kind of when I split off of family medicine, my practice only does restorative reproductive medicine now. So I'm only doing women's health and focusing on that side of things. So I don't deliver any babies. I leave that to the doctors who love doing that and who specialize in that. I love delivering babies in residency. I didn't love the hours and my body hated all the time of the night hours. So I kind of work with women throughout the rest of those pieces and kind of help pair them with a proper obstetrician to work with them or a midwife if that's what they're doing. And then we kind of work through that process. But everything up until that time, before, after, I see teenagers that are starting their cycles all the way through women who are kind of starting to go through that menopausal transition and really help to navigate any menstrual cycle concerns, any fertility concerns that may arise along the way.
Okay. Oh, that's fantastic. That's awesome. Because we need full on like OBGYNs, obviously, for all of the obstetrics and pregnancy and all of that and delivering babies. But we also need really good before and really good after care, especially when women are struggling with infertility and things like that. Like we need people like you that are willing to go deep dive into that. So you talked about how your practice is only focusing on restorative reproductive medicine. So can you just give us, what does that mean?
Yeah, so that term is something that a lot of people maybe haven't heard of before, but really we kind of look at it, I explain it kind of like an umbrella term that helps to understand, hey, we want to get to the underlying conditions that are causing issues. So for example, infertility in my world is not an end diagnosis. Infertility is oftentimes a sign or a symptom of some other underlying medical condition. And so when we're really looking, I like to say we're playing detective, right? Where we look for the why and we keep going 7 layers deeper until we say, okay, what is the truly most underlying cause we can find that's causing that? And then really start to correct those pieces. So the term restorative reproductive medicine has actually been around for about 20 years. And there's actually an International Institute of Restorative Reproductive Medicine founded back in 2020. Oh, I'm sorry, in 2000. So it's been around for about 25 years at this point in time. And so really their focus is on worldwide bringing together doctors, healthcare professionals, educators, charting instructors, like-minded individuals who are really focused on improving the overall health of women, but most importantly, bringing education and empowerment to women and couples to say there is a better way forward. And if you don't want to go the way that your conventional medicine doctor is taking you, let's help you to learn a new system, and let's pair that up with the medical side of things that can really help to move things in the right direction. And so really trying to bring that terminology to the forefront. We're seeing it start to get picked up a little bit more in mainstream media, as well as just discussions regarding improving fertility rates worldwide. And so really just hopefully helping to bring that kind of education to people that there is this other way forward that is legitimate, that is well tested, and that really, really works well in order to help get to those underlying causes that are at the root of so many issues with women's menstrual cycle health and fertility concerns.
Right. Yeah. And there's so many. I mean, I feel like most, maybe not most, but a lot of women now are getting on the pill, not necessarily for contraceptive reasons, but because they have painful periods, irregular cycles, acne, like all of those. It's now a medicine rather than a contraceptive sometimes. Right. So I'm seeing that more and more, even with my own patients. Now I also work at an OBGYN clinic. So maybe that's why I'm seeing more of those. But you mentioned conventional medicine, and you said that there are, women that are unhappy and unsatisfied with the care that they're receiving in conventional medicine. So can you dive more deeply into what kind of care is conventional medicine giving women, and what's different about the care that you are giving them?
Yeah. So first of all, I would say that a lot of the doctors that you would go to see are practicing conventional medicine, and it's not because they think that's the best option. It's truly just sometimes the only option they were taught. So even for myself, going through medical school, we were taught if there's a problem with a woman's menstrual cycle, no matter what it is, it's probably something hormonal. So birth control will help to regulate it. And it has kind of become this one size fits all approach for all of the things to fix. Now, in my practice, I like to explain and I say, okay, if you are a teenager who is a female who comes in and you are, having problems with acne, we're going to look at what's the underlying causes of that. Because if I saw your brother who's a teenager who also had acne, I would not put him on birth control. So why would I jump to that for you, right? And so it
That's a
goes
good
back
point.
to that understanding of why, right? Again, that question of why, and why are we having the acne problems, and why are we having these concerns, and realizing that first of all, there are lots of things that can treat almost any symptom that may be going on, even if it is hormonal, that don't have to include birth control. And more importantly, for so many of these women, especially when they get started on it as teenagers, we're seeing much greater increases as far as mental health concerns, more difficult time coming off of birth control. And for many women, I'm seeing a lot of women on the other side of things who are now trying to get pregnant, and they've been on birth control for 10, 15 years. They stop the pill and their periods are gone. And just trying to get things regulated again can create these long-term problems for many women. And so really starting to say, okay, how can we work with your body? How can we use your menstrual cycle, your ovulation signs, the things we're seeing with your fertility awareness charting, in order to look at that as a symptom that something else is going wrong. Your body's using it as a red flag to say, hey, there is something going on. can we identify that as that underlying cause and work to correct that? So I think that's the biggest difference with conventional medicine versus what we do. Is conventional medicine in general, oftentimes we'll just say, well, here, let's do this oral contraceptive pill, or in some cases for fertility, well, we don't know what's wrong, you just need to go to IVF. Rather than what we do in restorative reproductive medicine, we look for the why and really dig deep to understand, can we correct that underlying why? Because ultimately, it's not just about, at the end of the day, okay, well, we want to make sure that you have regular periods and that if you're trying to get pregnant, that you're able to do that. I'm really focused on what is your overall health, and that oftentimes these things that are raising a red flag are signs of bigger health conditions, whether it's, thyroid conditions, whether it's metabolic disturbance, whether it's pre-diabetes. There's all these things that can make your cycles go crazy that are underlying health conditions that absolutely need to be treated. So we're not looking just for the quick fix. We're not looking for the band-aid approach. We really are looking for that deep healing so that we can have better health for the long run, regardless of what your intentions are.
Oh my gosh, that's everything. Everything is just so good. That what you said about if a teenage boy were to come to you with acne, we wouldn't put him on the pill. I mean, I have never heard that before, but it's so simple and it makes so much sense. And it's like, why are we doing this to our
Yes.
young teenage girls? Oh, that was great. That was a really good point. Now, another thing you said that I want to dive deeper into is, women that have been on the pill, especially when they've been on for 10, 15 years and then they get off and they're trying to get pregnant and they can't. Is that something that we can definitively say now that that maybe long-term use of the pill causes infertility? Can you unpack that a little bit? Like, is that a true statement, or are there other things involved there?
Yeah, as with anything in medicine, I always say there's very little that's black and white. However, what we find is that there are certainly some women that stop the pill and they get pregnant the next month, and that
Right.
absolutely can happen. However, in my practice, and I've been doing this for about 13 years now, I would say that in general, the longer someone is on birth control, for the most part, the longer it takes for them to get cycles back to regular. Now, it's going to be very dependent upon what were her cycles like at baseline, because in many of these cases, they were started on birth control in the first place because their cycles were irregular already. So, for example, in the case of a woman who we end up diagnosing with PCOS or polycystic ovarian syndrome, she may have been put on birth control because she wasn't having regular periods. So now she got put on birth control and had these quote unquote normal cycles where she wasn't actually ovulating, so it wasn't an actual cycle. And then we take her back off the pill, and guess what? She doesn't go back to having normal cycles again. And so
Right.
that's her baseline. And so in some cases, it's more this piece that we never fixed the underlying problem to begin with. And in
Right.
some cases, then that's compounded by, being on birth control can have some lasting impacts. In many women, it will change significantly their testosterone levels, their estrogen levels, their thyroid function, their adrenal function, their cortisol. I mean, all of these pieces that then have to be restored over time. And so, now we're dealing with trying to come off of the pill and in some cases deal with the underlying situation that never got corrected in the first place. So I think there's definitely multiple layers and multiple facets to this, but it is definitely more challenging sometimes the longer you've been on something. And I would add not just birth control, even an IUD, and that many
Mm.
women are told, hey, an IUD is a safer option, or especially like a copper IUD doesn't have the hormones in it. And so a lot of women are told, well, that's safer, that's going to be better for you. We still see issues even with when an IUD is removed with just getting cycles back to regularity, again, because oftentimes they're placed because things were not regular to begin with. So really it takes that kind of fine tuning in order to say, okay, how do we go with a stepwise approach to come off of it, A, so that you don't have terrible symptoms, and B, so that we can say, okay, what if this is, if we're checking labs, for example, how much of it is this is because of the birth control you're on, how much of it is this is your underlying cause. And sometimes it takes a while to figure that out, and the waters can be a little bit muddy for a while until we can kind of go, okay, now we're off birth control for 6 months, maybe your hormones are actually your baseline. But it can really take quite some time for some women.
Yeah, that's a really good point too. It's not necessarily always the pill giving them the symptom of infertility, because it could have been that they already had an underlying issue before that's just been covered up.
Correct.
And so what I'm hearing you say is that the pill, first of all, it's obviously it's not healing anything. We've gotten there. We know that it is really just covering things up. But then not only is it not helping the situation with whatever actually is going on with the woman's body, but then it can also be exponentially worsening whatever is going on. And so when she gets off of it, not only is her body trying to return back to this baseline, but then there could be a whole other thing that has to be dug up of what was actually covered up in the first place by the pill. So it's kind of like a twofold. So
Absolutely.
wow, that's interesting. Yeah. And that actually kind of goes along with my own story, because I also have PCOS and I was put on the pill at 16. Now for me, I was only on it for about 2 months because it made me really moody. And so I think that's by the grace of God, to be honest, because I did not go back on it. And I learned how to chart my cycle, and now we're here today. But so many women don't have that story. And so you're absolutely right. Going back to the idea of then, this restorative reproductive medicine, you talked earlier about how you're trained in NAPRO technology, but then you're also trained in FEM and neo-fertility. Can you go into what are those words? Like, what do those things mean?
Yeah. So if we really to break it down, they're kind of like different methods. So I tell people it's kind of like speaking a different language, but still communicating similarly. So if we were to go to, for example, South America, we're going to have the same general understanding of each other, but within each region, it's going to be different dialects, different little pieces, different slang, different lingo that we use. And so really that's kind of how I explain it is that we're all going with this same effort towards really restoring these natural menstrual cycles, but sometimes in a little bit different approach. So for example, NAPRO technology was really one of the big pioneers as far as creating an actual medical platform for how we interface with what women are seeing in their charting and what we do from a medical standpoint. And then some of these other methods had said, okay, well, this is great. This is a good starting point, but we really see that this other piece has been left out, or we want to include this in it. And so they really dug deep into that. Or neo-fertility, for example, is founded on many of the same principles as NAPRO, but they've taken it a step further and said, okay, we really want to focus just on the fertility component of women's health. And so have created some additional things in that regards. And neo-fertility in particular also does a big service with addressing the male side of infertility, which some of the other methods don't do as much of. And so, there's kind of these different facets. And so if somebody comes to me and they say, okay, well, I want a consultation just from strictly one of these perspectives, I could maybe do that. I'd have to turn off my brain for some of the parts, but it really becomes this whole, every single piece of this is moving it forward. And certainly there are many of the principles that we utilize in different ways. And sometimes there are cases where we say, look, I have done everything. For example, I've done everything that NAPRO says to do, and I'm still stuck. And then I go, wait a second, I have this other thing that I could try that was from my FEM training or from my NEO training. And we try that, and that's the magic switch. And so our hope really is that as we continue forward with kind of this umbrella of restorative reproductive medicine, that we can really start to say there's so much more that we have in common and not as much that we have different, and really just saying there's so many of us doctors that have been trained now in multiple methods where we go, okay, all of this is working towards good. Like, how can we all continue to use this in a way that helps to advance things and helps to improve the care that our patients receive?
Yeah. And you are absolutely right with, if one facet has information, we need to be sharing this. We need to be working together. I say the same things with all of the different methods that you could use to chart your fertility. I mean, there's quite a lot. And I'm like, I always say the best one to choose is the one that you're actually going to use. Because and they all have their different benefits. They all have their drawbacks, and the best one for you is the one you're going to use actually.
Yep.
So yeah, I love that. I love it. So can you start diving into then what are some, with your practice with women young and old, that are coming to you, what are maybe the top 3 things that you typically see symptom wise? Like, why are they seeking you? What are the things that you see commonly? And then where do you start diagnosis? Like, do you have them chart their cycles? What kind of blood tests do you do? Like, can you just kind of go into the preliminary idea of when a client comes to you, what are they typically seeing?
Yeah. So I would say probably about half of our clients right now are fertility clients. And so what that means is people that are either dealing with primary or secondary infertility. So maybe they've had a baby in the past but are having a hard time getting pregnant again, recurrent miscarriages, pregnancy losses, pregnancy concerns. So that's probably about half of our clients. And then the other half would be those with menstrual cycle concerns. So of those, probably the most common we do see quite a lot of women that are struggling with PCOS or anovulatory cycles. So they're just not having regular cycles. And then we do also see a fair amount of PMS or PMDD, so premenstrual syndrome or perimenstrual dysphoric disorder, kind of more of those mood disturbances that come along with symptoms. And then I would say probably another one that I can't exclude would be painful periods. It's so common that women are told, well, yeah, they're your period. Like, of course they're going to be painful. No, just because it's common doesn't mean it's normal. And so we're really helping to try and break down that stigma that, you don't have to have terrible pain that you're missing work and school and life for just because you're a woman that has a period. And so those would be probably the big things that we look at. Now, it's not always clear, right? A woman doesn't always come in with a sign on her forehead that says, I have PCOS, right? And so oftentimes she might come in presenting and saying, hey, we've been trying to get pregnant for 2 years. We don't know what's up. And so what that typically entails is that we always would start with charting evaluation, because I really believe in educating women and couples to be an active role in what's happening. And in order to do that, we want to be able to give them the language to communicate with myself, with their charting instructor, in order to be able to have that back and forth and understanding not only when do we need to time labs and ultrasounds and medications, but also to be able to communicate, hey, something is not right, or I don't, what this thing that's happening on my charting isn't quite right. So we always have them work with one of our charting instructors first. And then we typically will do medical evaluation. Now, sometimes we switch that order up depending on what's going on. If you're having terrible symptoms, I don't make you wait for two cycles of charting to take care of pain. But medical evaluation, then we generally will try and time that lab draws 2-year cycle. Sometimes we check an ultrasound depending upon what your needs are. If there's fertility concerns, we also are looking at that male factor typically from the start. And then once we have those clear diagnoses, that makes treatment super simple. Now, I would say simple from my perspective, because that's how my brain works. But if we have the diagnosis, it makes the treatment plan so much more clear, rather than just like, well, I don't know, maybe we should throw birth control at it. We go, no, I've got a diagnosis now. You have PCOS, you have thyroid dysfunction, you have this, that, and the other. And that makes it much more easy to say, okay, because you have these diagnoses, these are the treatment protocols that are going to be beneficial for you. And this is what we're going to try in this particular order. And so it really becomes structured, and it really helps to kind of bring some light and bring some clarity into, when a woman comes in and she says, I don't know what's going on. I haven't been able to get pregnant for 2 years. And then we can sit down by that second visit and say, these are the 4 new diagnoses you have, and therefore this is what we're going to do. Then all of a sudden it's like, okay, I have a clear path forward. And so really just helping to kind of untangle that web of confusion, and sometimes they've been told bad intel in the past, really helps to get us on the right track by kind of utilizing that method.
And I feel like that brings so much peace of mind too, because when you're going through, especially something as difficult as infertility, sometimes the one of the difficult parts, at least, is just not knowing why, like having this quote unquote unexplained infertility, when in all reality, as you said, infertility is a symptom of some underlying issue. And so if we can get to that point where we can actually get a true diagnosis, okay, now we have a path forward, as you just said.
Yes.
So I feel like that, at least, it doesn't alleviate the pain of this symptom of infertility, but it at least gives you a peace of mind of like, okay, I'm being taken care of now. Like there is a path forward, and that in and of itself can bring can bring so much peace. Yeah,
Yeah.
a question popped to my mind though when you said painful periods. So when I think of painful periods, my brain just goes straight to possible endometriosis. So and I don't know a lot about endometriosis, but what I do know just from being a Creighton method trained person and in kind of the NAPRO technology world is that endometriosis can really only truly be diagnosed and treated through surgery. So can you go into that a little bit? And like, if you see somebody that you are thinking maybe endometriosis is a possibility here, how do you, as I'm assuming a non-surgeon, how do you go about that?
Yeah, so that's a great question because, one of the terrifying statistics is that endometriosis diagnosis on average takes 8 years. I mean, that's just insane in and of
Yeah,
itself that a woman would have to
I've
wait
heard
8 years for
10.
diagnosis. Yeah.
Yeah,
So,
crazy.
so we say on average 8 years for diagnosis. And so one of the first things we do is that we screen for that on our intake. Now, our screening is shortened and we can certainly expand it if we need to. But there's a friend of mine who is a NAPRO surgeon, and she has a list of over 50 symptoms that can be related to endometriosis. And so she has
Wow.
patients go through that. But even in our practice, if I see somebody and on day one, they're saying, hey, I'm having painful periods enough that I'm either bleeding around the clock, or I'm sometimes missing work or school or life because of it, or if I don't take any medicine, I cannot function. That to me is not acceptable level of pain. And from day one, we're talking about let's get you in to see one of the NAPRO surgeons to have definitive endometriosis surgery evaluated. Now, there are some tools that I have in my toolbox as far as being able to say, okay, we can try some different medications in the meantime. We can work on reducing inflammation in your diet with lifestyle changes. Low dose naltrexone is a beautiful, lovely medication that we use a lot for endometriosis. None of that cures endo, though. And so all of those are kind of a stopgap until we can get to that point. And so really, like I said, it's all about screening is the biggest thing. The tough thing, though, with endometriosis, and part of what makes it so tricky is that there are cases of women that have endometriosis that have no pain. And
Mm.
usually in those cases, we'll find them if somebody has been dealing with infertility. We get through our whole infertility workup. Everything is lovely. Hormones are balanced. Cycles look brilliant on paper. We're 6, 7, 8 months down the road and there is still no pregnancy. I'm always thinking about silent endometriosis, meaning there can still be endometriosis spots present, but you may not have pain. So it's one of those, we almost never cross it off of our list until we have that surgical evaluation, because as of
Wow.
right now, no ultrasound testing, CAT scan, MRI picks it up 100%. There's no lab testing. There's nothing else right now that is currently available as of June 2025. Now, there
Yeah.
are lots of things on the horizon. There's a saliva test over in Europe that is showing some promise. There are
Wow.
different impedance tests that look kind of like a little TENS unit or electrodes that you can put on your belly. That's showing some promise. There are some blood tests that they're working on. There's actually just a huge, huge grant over in Australia looking into endometriosis research and how do we identify, diagnose, and treat it more quickly, more accurately, because it is so challenging. But as of right now, it still is just that surgical evaluation. But I tell you what, my patients are willing to drive whatever it takes to get to the good surgeons. And so if you are somebody that is struggling with endometriosis or suspected endometriosis, please, 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 please do your research, contact myself, contact somebody else who lives in this world to get into the right surgeon, because not all surgeons who can treat endometriosis do it well. I will put a NAPRO surgeon up against any old surgeon any day as far as where I would send any of my patients to get endometriosis surgery. So they are just heads above as far as how they treat it, how they deal with adhesion prevention and scar tissue, and being able to preserve fertility. So that makes all the difference in the world if we think that you have endometriosis. And you're right, I'm not a surgeon, so you can't come see me for surgery. Sorry. But it is so important to make sure that we get plugged into the surgeons who know what they're doing, who are well trained to manage this if you need that.
Yeah, absolutely. And also shameless plug, we do have one of those NAPRO surgeons in Phoenix. So if you're listening to this and you're in Phoenix, we do have one. Her wait list is a little long, but it's because she's good.
Worth the wait.
But yes, yeah. So I had no idea that there was so much research being done. Saliva tests, like That's phenomenal. I
Wild.
really hope that goes somewhere. Yeah. What do we do though with, I mean, are these people that are doing this research, are they all of the mindset also of that restorative reproductive medicine? Because right now, in my understanding, is that if somebody has quote unquote has endometriosis or suspected to have endometriosis, a conventional doctor is going to put them on the pill. And I've had clients actually that I've worked with who were on the pill because they've been told they had endometriosis and that the pill was going to stop the spread of the endometriosis. So all of these people that are doing this research, do they have the same mindset as us in this restorative reproductive medicine, or go into that a little bit?
Yeah, so I think there's a mixed bag. Certainly there are the people that are in it for financial reasons, right? So sometimes
Yeah.
the tech, the devices, certainly we see a lot that goes on in women's health where there are new tech devices and gadgets and those types of things. So for some people, they're in it for that. Some of the newer studies that are coming out, though, are looking at, what are the solutions for it long term? And I will say, for a lot of doctors, what happens is that we find all of this endometriosis surgery that's happening, and it's perhaps subpar endometriosis surgery. So, for example, I will say I have had patients in the past who have had endometriosis surgery, and they were told, we can do endometriosis surgery, but you're going to need to come back again in a couple years to have it excised again. Or, hey, you can do this surgery, but you have to get pregnant within the first couple of months. Otherwise, your chances go back down again, and then you'll have to come back again before surgery again. And so I think this kind of culture of it's normal to need to have repeat surgeries has led a lot of doctors to say, you know what, if you need to go through 4 or 5 or 6 surgeries, like, why would we even do that? Let's just put you on the pill. Let's just suppress things. If we have to do surgery, we'll wait until you XYZ, need to get pregnant, need to get off birth control, whatever. And so the problem is that we're not comparing endometriosis surgery with the surgeons who are exceptional at endometriosis excision. So there was actually a naprosurgeon recently who, I think it was either last year or 2 years ago, he published a paper looking at his rates of recurrence after good endometriosis surgery. And if you look at nationwide, it's something ridiculous, like 40 to 50% of patients have to go back for repeat surgery. And his rates, when he was using these techniques that he was utilizing through napro technology, his rates of recurrence and needing to go back for repeat surgery, even for a 10-year follow-up, was at 2.5%. I mean, just unheard of. And so if you talk to patients and you say, okay, well, do you want to go and have to have endometriosis surgery and have to go back every 2 years? Of course, they're going to say no. But if you were to tell them, would you like to go for surgery, have a one and done surgery, and most likely never need to go back for surgery again and not need to be on birth control and all these other things, of course they're going to want to do that. So I think that's part of the narrative that needs to get shifted is to say not all endometriosis surgery is created equally. There is so much out there that needs to be done in order to help advance really good surgical techniques. And again, unfortunately, a lot of it comes back to what's the reimbursement for that. So for example, a surgeon can do a 30-minute endometriosis surgery. He can burn off 2 lesions and he gets paid X number of dollars to do that surgery. Another endometriosis surgeon can take 7 hours and they can meticulously go through, cut out each specific spot, sew it back together, do scar prevention. They spent 7 hours on surgery. They get the exact same X amount of dollars, because that's all there is in the insurance system right now, is there is one billing code for endometriosis. Now, they can get creative somewhat, but man, it is so hard to just say, okay, I can do 30 minutes of surgery, I can do 7 hours of surgery. And obviously there are great surgeons out there that are doing the 7-hour surgery and are doing exceptional, wonderful things. But unfortunately, just from a standpoint of availability, accessibility, financial income and gain, all of those things, unfortunately, we're seeing a lot of the surgeries that are taking place that are not that high quality of surgery.
Wow. Oh my goodness. Well, and I think also just the education of it needs to be really upped as well. Cause I actually have another client that I'm thinking of who told me that her last doctor, so not at my clinic, but her last doctor told her that they found endometriosis on her uterus in an ultrasound, which we know that's not possible, at least as of right now. But so she underwent surgery to get the endometriosis out And they opened her up and there was none there.
Wow.
Yeah. And I just, and then now she's in great hands, but my heart just broke for her because there just needs to be so much better education here too.
Yes.
Now I'm so glad you dove into that because yeah, I did not know a lot of that. That's wonderful. Let's flip the coin really quick because I think let's go into PCOS because I feel like, correct me if I'm wrong, but I feel like those are the two main players with all of these like irregular cycles, painful periods, all just the typical things that we're seeing right now. Those are the main two things that, at least at my clinic with the women that I'm working with, whether they're single, married, trying to get pregnant, trying to avoid whatever they're doing, those are the two main things that I'm seeing. So tell me a little bit about PCOS. What are the typical symptoms that you see and how do you go about treating that?
Yeah. So PCOS, first of all, affects about 10 to 15% of women worldwide. And so it is a very, very common diagnosis. So in my practice, we still follow the standard criteria for diagnosing PCOS. And so for me, that means we're looking primarily at three different things for diagnosis. The first is typically irregular cycles or signs that she's not ovulating. So sometimes that's just really irregular cycles. Sometimes she might be charting and we're not identifying ovulation that's happening. The second is that we can see ultrasound findings that are indicative of PCOS. So typically that's going to be enlarged ovaries and or multiple small follicles on the outside parts of the ovaries. And then the third piece is either clinical signs or lab signs of elevated androgens. So thinking your excess testosterone. So for many women, they're dealing with excessive facial hair, body hair in other places, acne, deepening of the voice, some of those pieces. Now, technically, in order to have a diagnosis of PCOS, you have to have at least two out of those three criteria. Now, there is some wiggle room depending upon your age, especially if you're a young woman. They say you can diagnose it just on the irregular cycles and the facial hair growth or some of those pieces. But really, it comes down to making sure that we stay within those three criteria. Now, as you can think, I did not mention anything about what do your other labs show. I did not mention anything about weight. Now, those are the two things that I see most commonly that get misdiagnosed. So oftentimes I see a woman that comes into me that is overweight, that has irregular cycles, and her doctor tells her she has PCOS because she's overweight and has irregular cycles, but doesn't have other symptoms or hasn't been evaluated. And so that's something that's really important for people to know, is that unfortunately PCOS is misdiagnosed sometimes. The other is that you don't have to be overweight to have PCOS. We have all different body types and sizes and shapes of women that can have PCOS. And so once we kind of say, okay, where do we see those symptoms? And of those three criteria, then we start to separate it out and we break it down into four main subcategories of PCOS. So one type has all three of those criteria. And then the other three types are just a combination of the different two of the criteria. And then even to complicate things a little bit more is that even within each subtype of PCOS, women may or may not have different features. So for example, many women struggle with insulin resistance, meaning they have a hard time regulating insulin or blood sugar, which can lead to weight gain and metabolic dysfunction. But it's not seen in all women with PCOS. So in our practice, we always are looking for that to see if you have PCOS, do you also have insulin resistance? Because if you do, we want to treat that really well because that can oftentimes help some of your other symptoms in addition to helping improve ovulation and your weight and making you feel better overall. We oftentimes also will pick up thyroid dysfunction or adrenal dysfunction. So things like cortisol problems or DHEA problems, or again, even that excess testosterone can cause lots of symptoms. And so even within my practice, if I see 4 patients in a row that all have PCOS, none of them are on the same treatment plan because we are really working to individualize each treatment plan based on what your individual findings are. And that makes all the difference in our outcomes. People are able to have improvement of their symptoms, they have improvement of their cycles, and then we're really able to move the needle when it comes to PCOS. So I think that's where it makes the biggest difference is in, first of all, making sure we have the accurate diagnoses, figuring out what are the other diagnoses that go along with that, and then really helping women to feel their best and understand, okay, how much of this is my PCOS? How much is it maybe the thyroid part or the metabolic part? And really then being able to focus and tune in on how do we make those symptoms improve for overall return of cycle health.
Yeah. And now I know that even farther down the line with PCOS, because, lifestyle, diet change, those are huge for PCOS, and then medication when necessary. But I know even down the road, on the topic of surgery, there is the ovarian wedge resection surgery. How often do you see your patients having to go that far into treatment to need that surgery?
Yeah. So it's interesting. If you look back historically, ovarian wedge resection was a treatment that was offered to many patients with PCOS before the birth control pill came out. And then once the pill
Oh,
came out, ovarian wedge resection went away or largely went away because people were just like, okay, well, I'll just go on the pill and that'll help fix things. And again, ovarian wedge resection is one of those treatments that actually can be curative of PCOS, right? Like some women will still deal with some of the symptoms, but when we remove some of that excess ovarian tissue, we see significant improvements in ovulation function and an overall functioning. So back to your original question though, as far as how often do I see that? Most of the time when I have patients that are undergoing ovarian wedge resection, it typically is in conjunction with evaluation for endometriosis because unfortunately, PCOS and endometriosis run hand in hand, estimates somewhere between 50 to 60% of women. So most of the time, if they're getting evaluated for endometriosis, the surgeon is also talking with them about doing ovarian wedge resection at the same time. I would
got
say it's
it.
much less common currently for me to send a patient just for ovarian wedge resection. Nearly all the time, we're able to get symptom control, symptom improvement, relief, regulation of cycles without having to go the surgical route. Like I said, the one spot where that changes is if there are also concerns for endometriosis or sometimes also concerns for fertility, in which case then sometimes we're knocking on the surgeon's door. But again, by and large, generally it's happening in conjunction with that endometriosis surgery. I mean, that's the one beautiful thing about it. If you have to go in for surgery, they can take care of all of it right there.
Yeah. That's a really good point too. It makes me think of another client that went in for surgery for endometriosis, and she also had an ovarian wedge resection done because
Mhm.
they found both, because it is so
Yeah.
common for women to be experiencing both of those things. Now I know I keep going on like weird different tangents here, but I'm just like, I'm like, you are such a wealth of knowledge, and I just I want to get it all. But another flip of the coin, you were talking about earlier about obviously infertility we've been talking about, but secondary infertility. So, endometriosis, PCOS, all of these things, in my personal, not practice, but in my personal just teaching women how to chart, I've seen this. In your practice, you've said you've seen this, but then how do those or anything else play into secondary infertility? Like how does that happen? And what are some of the treatment options that you have for that?
Yeah. So secondary infertility is really tricky and it affects somewhere between 12 to 15% of women. And so again, we define that by saying somebody who has had a successful pregnancy, full-term pregnancy in the past, and then goes into a period of time where she has a hard time getting pregnant. And so in some cases, it can be fairly straightforward. Sometimes it's just a little tweak of a thyroid medicine or optimizing hormone levels. But in other cases, it's just like we're starting from scratch with a fertility workup, especially in cases where maybe the first pregnancy came really easy. Maybe they weren't even trying, it just happened. And they go, cool, this was great. This was, no problem. I stopped birth control and like a month later, I was pregnant. And then we go into this period of time where they're like, and now we're waiting. And like now our baby is 3 years old. We wanted to be pregnant a year ago. And so we can really get stuck. And so most commonly what we see is some sort of ovulation dysfunction. Very commonly, it can be caused by thyroid problems. So for many women, if they develop thyroid dysfunction, postpartum is a very common time we see that. And so sometimes that's not picked up on. The other one that plays a huge role is stress. Now, we all know that, like intuitively, we know that stress can throw off your hormones. But if you're caring for a toddler and a family, and some women are, return back to work, or some are trying to do the stay at home mom thing, which is a full time job and a half, all of that can add to stress levels. Your
Yeah.
sleep can change, what you're eating has changed. And so sometimes, even though you think, if you look at it from the big picture, you're like, I mean, everything's the same. I'm doing everything the same. The reality is nothing is the same. After you have even one kiddo, your life is forever changed, and how you function on a daily basis changes, and how your lifestyle changes. And so sometimes it's a matter of really digging deep and going, okay, let's dial it back and let's really focus on sleep, or let's really focus on, you know, meditation, deep breathing, prayer, whatever that is to help with calming stress levels down and really kind of talking through those pieces. And oftentimes we find that a lot of those things have just kind of been a slow slip into change, right? So much so that you maybe don't even realize it. But then you go, actually, if I look back, yeah, my weight is up 20 pounds from where I was last time I got pregnant. Or, I used to sleep 8 hours a night and now I'm getting about 6.5. And so we can still function with a lot of those things, but you might not realize it for what it is. So again, sometimes it's easy and it's those small tweaks. Sometimes it truly is a full deep dive. We go into the whole shebang. And in some cases, we're going as far as, surgical evaluation, medications, bringing in specialist consultants, autoimmune, inflammatory marker, all of the things. So it kind of depends, but you're right. It is one of the most frustrating things that we treat. Even I think my clients that have secondary infertility are probably even more frustrated than the ones that have primary infertility that have never been pregnant, because they're like, what the heck? This happened before.
Right.
And I hardly blinked and it happened. I have a patient that jokes that she's like, we always used to just like look at each other from across the room when I was pregnant. And then all of a sudden it stopped. And so, sometimes it can be really frustrating to kind of figure it out. But yeah, secondary infertility is, we treat it similarly to primary infertility. The only thing is we've got a little more hope knowing like, hey, we've been able to get there before. We just need to crack the code and figure out what changed, what shifted, and get back to that baseline.
Yeah, yeah. Now, if you are seeing a woman again with secondary infertility and you have to do the whole workup, whole shebang, and you realize, let's say she has PCOS, could that mean that she didn't have PCOS with her first pregnancy, but then it developed over time? Or did she always have PCOS, but the first pregnancy wasn't affected by it? Like go into that.
Yeah, great question. So what I tell people is that if we find, as we go through an infertility workup, if we find 8 things that are going on with your cycles between you and your partner, if we find 8 things, we don't have to fix 8 things. We probably have to fix 6 though. And so in our world, we call that getting away with it, right? So maybe you can get away with having endometriosis if the rest of your hormones all look normal. Or maybe you can get away with having PCOS if you happen to catch a cycle that you actually ovulated. And so there are certainly cases where we go, okay, it doesn't have to be perfect. The downside is that every time you want to have the next pregnancy, you are older. We cannot change that factor. And so in all cases where we're talking about a subsequent pregnancy, we're always fighting age, we're always fighting time. And so sometimes we say, okay, when I was 22, I had PCOS and I had thyroid dysfunction, but I was young. I was able to get pregnant easily. Okay, now that I'm 32 or 35, I still have PCOS, I still have thyroid dysfunction, but now I also have age working against me. So now I can't get away with having the PCOS and leaving it untreated as easily. Does that make sense?
Yeah, it does. It
Yeah.
does. And is the reason for, I mean, obviously with age, right, you don't have as many eggs, you're closer to menopause than you were, but even from a distance of 22 to 32, is it because her eggs aren't as like the quality is not as high with that? Like what is the biggest concern with age rather than obviously like the amount of eggs there?
Yeah. So when I think about age with number of eggs, I don't get as worked up. As long as you're having regular cycles still, we're pretty okay. We do start to pay attention to quality of eggs. Now that can change over time, but oftentimes that's impacted by lifestyle. What does your ovulation function look like? And then the other thing that oftentimes gets overlooked is that male fertility factor. So women, the eggs we have are the eggs we have. We're born with them. They're the same eggs we have for the rest of our lives. But for men, they are constantly creating new sperm, and that changes over completely every 2 to 3 months. And so, if there are other factors that are going on the male side of things, maybe he's picked up a bad habit, maybe he's gained 50 pounds, maybe he's been sitting in the sauna on a daily basis. All of those things can have a huge impact, not only on sperm count, but also on quality. So, when we look at the DNA of that sperm, and so that's why it becomes really important that we're looking at other factors that may be associated with it. One of my biggest pet peeves is when people start to freak out when they turn 35 and they're like, oh my gosh, 35, like my ovaries are dead and crippled, like I'm not going to be able to get pregnant again. Like there's this underlying kind of thought process that's like, okay, 35, like that's the new 55, like you might as well just give up. And so many women are being told, freeze your eggs, consider donor eggs, all
Mm,
of these things at
yeah.
that magical age 35. And part of the reason for that is that if we look in the medical literature and if you look at IVF success rates, they drop drastically after age 35. But if you look at the success rates for pregnancy beyond age 35 for restorative reproductive medicine, we have a slow decline, but it's not like this drastic drop off at age 35. And so if you talk to those of us that work in this field of restorative reproductive medicine, we've seen patients get pregnant into their 40s. My patient who carries the record currently, she was 44 when she got pregnant and went on to carry a full-term successful healthy baby pregnancy to full-term pregnancy. So it's not just about this magical age number. It's all about how are we optimizing the different factors that come with your health? What is your cycle showing us? And how can we help to optimize and improve the pieces that we can have control over? Because I can't change your age. That's just, it is what it is. We'll just control and try and correct the other factors where we need to.
Yeah. Yeah. Oh man, this was great. And I just realized we are like almost, well, at 50 minutes or almost at an hour. But I feel like I could talk to you for so much longer because this is so good. One more thing I want to get into before we end our time is are you fully telehealth or I know you said you're in Iowa. So can people go to your clinic or are you completely telehealth? Tell us a little bit about the logistics of that.
Yeah, we have a beautiful, beautiful building here in Cedar Rapids, Iowa. And it backs up to the woods and it's nature and it's so lovely and relaxing. So we do see
Amazing.
a fair amount of our patients here in person. But we do have a large majority, probably about half of our practice is telehealth because like I said, we see patients from all over the country and some international clients as well. And so I think that's one of the really beautiful things about the work we do in restorative reproductive medicine is that we can do so much virtually. We can do so much via telehealth even in situations where we need to have eyes on the situation, maybe an ultrasound or maybe an exam, we can at least help direct you to, okay, here's where we need to have that done, or here's who can help us accomplish that. And so it really gives us the flexibility to be able to allow patients to access this kind of care no matter where you are. So, if I'm not licensed in a state that you're in, I'm always happy to get you plugged into somebody who can take good care of you. We are constantly expanding the states that we are seeing clients in. We're in 12 or 13 states right now and continuing to grow. So always happy to try and pick up other states from a medical standpoint if that's helpful, or get you plugged into a local resource is always best if that's a possibility for you.
Okay. And what is doing this all telehealth look like? Like, are you ordering the blood work done and the ultrasound? Like if I needed to get an
Yes.
ultrasound from you, like how does that work?
Yeah, we manage all of it. So initially the first visit we see where we're going to go through the history, we're going to go through, what's been done already, and then we go through a series of questions where we figure out, okay, what do we need to evaluate in order to get the diagnosis that we need. So from there we order lab work to be done. If you're out of our area, we order it at a lab that works best for you. If we need to do ultrasound testing, we would order that ultrasound to be done. And then once we have all the results, then we meet again for another virtual visit to go over all of those results and discuss next steps forward. We prescribe medications if needed. We recommend supplements if needed. We talk through lifestyle changes where appropriate. And so really being able to manage all of it the same as if you were seeing your local doctor, we do all of that stuff. We can send anything electronically anywhere in the country and being able to really continue to manage it that way. So it really becomes just that seamless care. The only difference is that I chat with you through the computer instead of face to face. So I always tell people though, if I come to visit your area, we're going to meet up somehow. That's just going to be the way it
Of
is.
course.
So that's why I have to pick up licenses in fun, beautiful, warm places so that I can sneak away for
There you
my
go.
Iowa winters.
Yeah, you don't want to be in Arizona right now. I will tell you
Yeah,
that.
fair, fair.
Oh man. Okay. Well, that's awesome. If somebody wanted to see you and get in touch with you, how can they do that?
Yeah, so best way to connect to us is through our website, which is radiantclinic.com. From our website, there's actually a link on that very first homepage that says book a free discovery call. So you can go to that link, you can enter in your information, and someone from our team will give you a call to discuss what your needs are. If the staff can't get your questions answered, they can plug you in with a direct phone call to me to say, hey, let's make sure that this is a good fit before we continue to move forward. So that's a great opportunity. The other is that I do have a podcast myself. It's called Cycle Wisdom. So if you want to hear more about a particular topic in the world of restorative reproductive medicine, go check out that podcast because there's so much information there. I have whole episodes just talking about PCOS. They're typically pretty short, 15 minutes or so. just so that you can quickly get a gist for what it is that we're talking about. But we're nearing almost 100 episodes right now. So really just a good wealth of information. So share that. I'd love to get education out to people just to let them know what's possible, and to really help to educate and empower women and couples to understand that there is a better way forward, and to really trust the knowledge of your body to understand that, hey, something's not right, but I know that I can do something about it.
Yeah. Well, Dr. Minjeur, thank you so much for being on the podcast. And I will put everything that you just said, I will put in the links to the show notes below so people can get easy access to those things, because you are such a wealth of knowledge and just such a good tool in the toolbox to be able to get healthy for all women. So thank you so much. I appreciate you being on.
Thanks, Haley. Take care.
Thank you for listening to the Truth and Fertility podcast. If you are enjoying this content, it would be amazing if you could leave a 5-star review. That helps me tremendously to be able to continue to produce these episodes for you. Remember that these podcasts are available on Apple, Spotify, and Amazon, and YouTube. And you can always go to my website, truthandfertility.com, to learn more. Thanks again for listening, and I'll talk to you again next week.